So thank you so much. We're really blessed to welcome Dr. Ran Littman, a clinical psychologist specializing in OCD and relationship OCD, or ROCD for short. Ran works extensively with individuals navigating doubt, reassurance seeking, and the impact OCD can have on relationships, using evidence-based approaches like CBT, REP, and ACT. In addition to his clinical work, Ran is a columnist for Psychology Today, where he shares thoughtful, research-informed insights to help people better understand and cope with ROCD. So today's conversation is about bringing clarity, compassion, and understanding to ROCD. What it is, what's often misunderstood, and how treatment can support healthier relationships. Ran, thank you so very much for joining us. We are incredibly excited. As I mentioned in the introduction, this is one of your specialties. You're one of the leading experts in this field. So we are incredibly privileged to have you join us. And I know that myself, in Stop OCD, and on behalf of the participants, we are going to be learning so much from you today.
Hi, Mariel. So thank you so much, and thank you for inviting me. And I'm glad to be here, and hope that our talk would be relevant and fruitful for people who either listen now or would watch it later on.
I have no doubt. I have no doubt. So maybe just to start off the conversation, if you could just share a little bit about yourself. Like I did a brief intro. I'd love for you to give a little bit more details, your background, your work in OCD, and how you came to focus in this area. And just to further elaborate on that, I know this is lots to take in, and we'll take it into small steps. But maybe how did your work with ROCD, first begin? And was there any particular, experience that drew you to this area? So give us a beautiful picture of Dr. Ran Littman, the clinical psychologist, and share with us a little bit about yourself.
I'll do my best. So, from the very start of my training as a clinical psychologist, I was very highly interested in cognitive behavioral therapy, CBT, later on in ACT, acceptance and commitment therapy as well. And this led me to work with Dr. Danny Derby and Professor Gay Derone, which are two prominent clinicians and researchers in the field of OCD and ROCD. And they were actually the first to have studied and published about the ROCD phenomena. So naturally, I learned a lot from them about OCD, about ROCD, about this concept, which wasn't very too familiar at the time, and in my opinion, still not known enough. And together with some other professionals, we established a team, a group that focused on further developing the treatment and the understanding and conceptualization of ROCD. So we conducted some research about ROCD. We further elaborated and deepened the therapeutical framework. We wrote a book chapter about OCD. We developed an online self-help program for our OCD. And of course, we worked with many clients and people struggling with this condition in a way that both clinical work and scientific research helped building one another and corresponding with one another. And I'm glad to say that I believe that we know definitely more about this condition and what to do with it and how to offer help with it than we did, say, 12, 15 years ago.
OCD is quite a specific topic or disorder. Was there any particular reason why you went into OCD and you zoned specifically down to ROCD? What was about ROCD that really interests you and that you wanted to do, spend a lot of your time focused on that? Was there anything in particular for you?
Yeah. So first of all, I also, of course, work with people struggling with the other additional conditions,
Mm,
mostly anxiety-related disorders, right? But well, I did find the work with OCD quite interesting and fascinating to begin with, both on the aspect that it has some communalities among different people struggling with different types of OCDs. So there is some um, structure which is, I wouldn't say identical, but sort of similar among different
mm,
OCD manifestations, but
mm,
still there's something very personal in every person. I mean, no person with OCD is similar to the other. There is always the personal world of the individual, which is always the fascinating and most interesting part to work with in therapy. And I think that one of the things in OCD and particularly in RCD, though, so drew me that it seemed that there was definitely lots of space to research. I mean, things we don't fully know sufficiently know about the disorder, about how to work with it, and as we do now, to try and like spread the word and have more people, more individuals, more clinicians to know that this is a thing,
mm,
that some people struggle with, and then there is a way to work with it. So those were some of the things that fascinated and drew me to keep working and focusing on that.
okay. Um, for those who do not know what ROCD is, we kind of just shared again, just briefly in the introduction. If you can explain for those in simple terms and accessible terms, what is ROCD? What does it
Yeah.
entail? And how as you mentioned it's slightly different from OCD, but what is it? And then maybe you can just explain why is there a subcategory then from the main OCD?
The short answer for what ROCD is would be people who are excessively preoccupied with doubts and questions and deliberations regarding their relationship, the suitability of their relationship, the suitability of their partner, their own feelings in a relationship,
Mm,
to the extent that it either take a substantial amount of their time or is accompanied by significant feelings of distress, right?
mm,
Or impacts negatively and hinders one or more important life domain, such as work, leisure, or relationship. I would like, however, to give a more elaborated, to go with a longer answer as well, that I
please,
think that would help us
please.
to get a better understanding of what
Mm,
ROCD is. And as you say, why do we even consider what I just described as a
mm,
manifestation form of OCD?
mm,
So OCD is a disorder of thought process, not of thought content. What does that mean? The thoughts, for the most part, the thoughts that people with OCD have are not different from the thoughts that people without OCD have. For example, just give you an example, thoughts like, am I sure that I locked the door? Or am I sure that
mm,
I didn't leave the stove on before I left the
mm,
house? Or maybe I got some kind of infectious disease now that I put my hand on the subway pole, or a thought that is very common among young parents. Could I harm my baby? Could I suddenly just drop the baby and harm them? Or
yeah.
thoughts like when I did or didn't do something, might this mean that some disaster would happen? Or can I get, maybe I got some determinal illness I just read about, and so on and so forth.
Yeah.
So most people, when they would hear those thoughts, they would probably say, well, yeah, I'm sometimes having those kinds of thoughts, like those of
Mm.
others,
Mm.
right? So the difference is not in the appearance of in those thoughts in themselves, but in OCD, those kinds of thoughts appear much more frequently. Right? They are usually very distressing, meaning they're accompanied by feelings such as anxiety, fear, sometimes disgust, guilt, shame. And and this is really an important aspect here, they are often regarded as meaningful. Meaning, if I think again and again about, for example, being contaminated or about having a health issue, and of course, if those thoughts are so distressing for me and so triggering for me, so it must mean something. It must mean something meaningful that I have to
Mm.
do something about or
Mhm.
react, right? And
Mm.
those reactions could either be physical acts or mental acts that people do inside their head. And this is what we call compulsions.
Yeah.
Okay? Now, going back to ROCD, the typical ROCD thoughts or typical thoughts that people with ROCD cope with are thoughts such as, are we compatible enough? Am I in love enough? Am I attracted enough to my partner? Do I feel what I'm supposed to feel? Right? Um, Sometimes those thoughts can be about their partner, like, is he intelligent enough? Is she
Mm.
sociable enough? Is he funny enough? Would she be a good enough mother? Is this the person that I see myself spending my life for the next 20 years with? And so on and so forth. And again, those thoughts in themselves are very, very natural to have in a
Mm.
relationship,
Mm.
right? In ROCD, they do appear very frequently. They're usually very distressing, meaning that they're accompanied by highly uncomfortable and triggering emotions. And people tend to view them or regard them as meaningful, meaning if I have those doubts, those questions coming up again and again and again, it must mean something about
Yeah.
me, about the relationship, about the suitability in of the relationship, and so on and so forth.
Mm. So could someone possibly then have those thoughts, and when you attach that meaning to it, oh, if I'm having these thoughts, then therefore it must mean that we're not a good fit, or that we're not meant to be with each other, or it must mean then that they are not, in fact, intelligent or attractive enough to be with me. Could you sort of associate that type of meaning with ROCD?
Yeah, definitely. So again, the one of the main features that keeps feeding the what we call the obsessive compulsive cycle is that we regard the appearance of these thoughts, right? Sometimes they can come as images as well, right?
Mm.
As something that I have to do something about, right? For example, just to clarify this a little bit, doing something about can be, for example, trying to seek reassurance, right, from either my partner or friends or
Mm.
family or therapists, or going online and getting immediate answer to those questions whenever they pop up. For example,
Mm.
a doubtful thought came up into my mind, and I'm feeling like very activated about it, and I feel that I need to gain an answer right now. I need to realize, am I in the right relationship or not? Is he
Mm.
intelligent enough or not?
Mm.
And then I either, initiate a conversation with my partner to see, like, well, does he answer right,
Mm.
intelligently? Or I
Mm.
call a friend, or I go online, say, like,
Mm.
how can I
Mm.
know this is a right relationship, or the
Okay.
partner is intelligent enough? But those compulsions can also be done internally. For
Mm.
example, by going into my head and starting deliberating. and thinking, well, 2 weeks in this conversation, he said something very silly, but on this other occasion, he said something very smart. So does it mean this? Does it mean that? Right?
Mm.
Sometimes it can be monitoring of my own feelings. Okay, so wait, I'm having this doubt. And now let's see. I think about my partner. Do I feel happy? Do I feel like extreme happiness? Do I feel extreme attraction? And what if I don't? And what does that
Mm.
mean?
Mm.
So there is, whether it's put more or less explicitly, there is definitely a lot of engagement with the meaning of what I'm experiencing, those thoughts and feelings.
Yeah. Um, for those who are maybe familiar with ROCD, or maybe for those who are not, and this is the first time they've been exposed to it, where would ROCD come from? Is a relationship a trigger? Have I always had it? Maybe explain a little bit where ROCD comes from and why a particular person may have developed it over
Yeah.
time.
Yeah. So I would start by saying that nowadays, in regards to OCD in general, we know to treat OCD better than we know to explain why it develops. Right?
Mhm.
Um, Having said that, well, with many people with ROCD, we also see some other OCD manifestations or tendencies. Meaning it's not uncommon to have someone come to the clinic and their most prominent issue now is ROCD, but when we evaluate, we see that there, was, sometimes still is, right? Other area or other areas on which the OCD caught on, or there are at least some OCD tendencies.
Yeah.
But for other people, it's also true that some people come and there is no, I mean, the OCD is not necessarily spread to other areas, and the area of relationship is the main focus of obsessions. Um, there can be some factors such as relationship model that people saw in their
Mm.
childhood. And again, it doesn't
Okay.
necessarily say that the model they saw in their parents is wrong or not
Mm.
okay.
Mm.
Sometimes it can look like a very perfect model,
Mm.
right? And then there is a level of comparison of thinking like this is the model I'm supposed to have. And
Okay.
then if I'm having thoughts, if I'm having doubts, if I'm having deliberation, what's wrong here? Okay.
Mm.
Um, I believe that nowadays social media, dating apps can also have an impact here. Again, this is not to say that because of the ROCD exists because of dating apps, but
Yeah.
the availability or the illusion of availability that there's so many options there, and maybe in just a few clicks I could find someone that I'll be happier with, right? More content with, more attracted
Mm.
with. And
Mm-hmm.
maybe staying with my partner, I'm actually missing out on all those
Okay.
opportunities.
Mm-hmm.
This could be a fertile ground for growth of doubts and questions. Yeah. So I think that those are some of the factors that contribute to the maintenance of ROCD.
I wonder if this leads then quite well into my next question then. If there are any common misconceptions that people have about ROCD, either from the general public or from clinicians specifically.
Yeah. Two major misconceptions I think of is, first of all, sometimes people, including some clinicians, who think like, well, it's not really a thing, right?
Mm.
Well, I mean, it's okay. It's a nice term that some people came up with, but there's
Mm.
no actually such thing. And I can mention here a study from about a few years ago that actually investigated a very large amount of people struggling with OCD, and a substantial number of them, right, um, describe struggling with relationship-related doubts and obsessions. I think it
Mm.
was something about a third of them.
Okay.
And I can also testify from mine and other professionals in the field working with this that when it is ROCD and the ROCD treatment is managed to be maintained properly, this can really bring into a very significant change in the way people deal with their doubts and in their relationship.
Mm.
The second misconception, which really relates to what we just talked about, is the thought that having those doubts means something about
Mm.
me, about my relationship, or and again, um, coming from this view in therapy too. So if it means something, so we need to think it over, deliberate about it together, analyze it as in therapy as well, which
Mm.
would, by the way, would be very relevant to do with people without ROCD. But with people with ROCD, this is exactly what they are already doing, and this
Mm.
is actually it's not a solution. This is a significant part of the problem.
Yeah.
So those are the two main misconceptions I'm
Okay.
familiar with.
Thank you. Many people worry that ROCD means the relationship is wrong. I think we kind of already described some of that, or that
Mhm.
they're with the wrong person. How do you, again, leading to what we've just spoken about, how do you help people make sense of that fear?
Yeah.
So maybe
This,
just give us a very brief, if we were a fly on the wall in your clinic or in your therapy room, what would you be working with them to try and make sense of that fear?
yeah. So this is a really good question that many of the people who cope with ROCD are really confused by, right?
Mm.
And I can say that this is a question that people often go back to throughout the process of therapy. And the things that we need to understand is when a person obsesses over their relationship, meaning, in other words, when they ongoingly react to every question, every doubt, every triggering situation, they're not enabled to actually experience the relationship, not through the glasses of their own fears and doubts, in a way that would allow them to actually consider those questions of the
Mm.
suitability, right? So I'll say it in other words. First of all, having ROCD does not mean that the relationship is wrong or flawed. It does not necessarily mean that the relationship is okay.
Mm.
Meaning, we work with people who sometimes have a very good relationship, right? Loving, supporting, very suitable, and they still obsess over it. And also get to work with people where there are problems in their relationships. And sometimes there might be insuitability, but they still obsess over it.
Mm.
But when ROCD is present, it is very, very hard, and I would say even almost impossible to actually regard those questions, those doubts of suitability regarding suitability, right, in a way that would actually allow the person to choose. Because when people with ROCD react to their doubts, their fears, their intrusive thoughts, they're often mistaken to think that they're doing something active in order to resolve the doubts and the questions. But
Mm.
what they're really doing, what they're actually doing, is trying to get rid of unpleasant feelings and thoughts. They try to get this sense of like anxiety go away, this sense of like, oh, okay, I know I got the answer, I got my certainty, right? which are often a very short-term solutions, which in the long run only teaches their mind that those thoughts are indeed significant enough. Why? Because if every time that it pops up, I react to it, so there must be something meaningful here.
Mhm.
Therefore, the next time when such thought would come up, I would feel like I have to react. Why? Because for the past 400 times when it popped up, I always
Yeah,
reacted. So now
yeah,
I must react again.
yeah.
So coming back to the start of your question, I think that one of the processes that as ROCD therapists, or one of our missions here, is to bring the client again and again when they go back into deliberating, wait, but maybe that's not even an ROCD. Maybe I'm just in the wrong relationship. Maybe I will just finish the relationship and everything will go away. When we know that ROCD is present, every time we have to help them get back, not to move back from the question of whether or not I'm in the right relationship to the question of when I'm constantly reacting and engaging in my doubts and deliberations, how does it impact me?
Mm,
How does it impact my mood? How
mm,
does it impact my attention? How does it impact
mm,
my ability to just be present in
mm,
whatever it is I'm doing, whether it's a
mm,
conversation with my partner or having dinner together or time at work, right? And again, the paradox here is that the more you try to constantly answer the questions that are bothering you, the less you give yourself, you allow yourself the space to actually gather the data that would enable you to answer those questions.
mm. Fascinating. I think you kind of answered my question that I was having in my mind that I wanted to ask you, but I wonder if participants would be interested. And the reason why I'm asking is just because of the nature of ROCD. Obviously, it's impacting the individual. The individual is having these intrusive thoughts and the compulsions. You're not, so obviously the individual is coming to you for treatment. It's not about couples counseling or relationship counseling. It's dealing with the individual and their intrusive thoughts. And I did want to ask you though, maybe to dispel this is a possible myth that maybe we haven't uncovered just yet. Do you often have the partner in room with and you incorporate them into the therapy, or is it just therapy specifically for the individual who's experiencing ROCD? Do you ever incorporate the partner into this situation?
So first of all, I do.
Mm,
This is not something I usually do at the beginning of treatment.
mm,
Um, but I often invite the partner. It's usually for 1 or 2 sessions. Okay? This is not, as I said, like this is not a couples counseling. Um, but one of I mean, typically there are three things that I like to do when inviting a partner. Okay. First of all, I like to hear about their experience
mm,
because up to this point, I'm usually quite familiar with the client's experience,
mm,
but I really want to hear from the partner. How do they experience when, when their partner is
mm,
obsessed or withdrawn, or they see that something is going over him, or when he comes to them again and again with affirmation questions, right? Um, how's it like for them?
mm,
Secondly, I like to give partners some basic psychoeducation about OCD and ROCD. And some
mm,
partners already come to therapy after they read about it, they're knowledgeable enough, so we don't have to spend too much on that. But with others, it's really helping them understand, first of all, that um, those thoughts and questions that their partner is having are very, very triggering. This is not something usual. This is usually a very, anxiety evoking, shame
Mm.
evoking,
Mm.
whatever, that they're coping with, right?
Yeah.
And also help them understand what we call the cycle of having those thoughts that are very triggering. They require, or the client feel that they require some kind of reaction, and this reaction keeps feeding the cycle. Thirdly, I'd like to discuss with both the client and the partner of how to best support the partner and not the OCD, which
Mm.
mainly is not engaging in compulsions, right? While still being very, very empathic to the distress the client, the partner is experiencing, right? Meaning, like, it can be something like, I really see that you're struggling. I see that this is something that is very triggering for you, that you're anxious, and I can sit with you here, I can hold your hand, I can hug you. But for example, I'm not gonna answer the question of that you asked me already 200 times, right? Of can I assure you that we will always be together?
Yeah.
Because know that this might, help you momentarily,
Mm.
but this will not support you in the long run.
Yeah.
Mm.
This is something that I wanted to ask you about. Again, in reassurance, when it comes to uh, what does it look like in typical relationships? Just that reassurance compared to reassurance in ROCD, and is it even can you even get reassurance from an individual who's experiencing ROCD?
So this question really goes back to the fundamental ways we described OCD, meaning
Mm.
that I'll give a few examples. Asking for reassurance in ROCD can be, as we mentioned earlier, um, asking people, close ones, like friends, family, um, therapists, right? So, do you think we're compatible? Do you think she's good looking enough? Do you think he's intelligent enough? Do you think that he's successful enough for me? Do you think that this is the person? Should I or should I not stay with them? This can be going online, Googling all kind of questions. How would I know if I'm in the right relationship? What does doubt in a relationship mean, and so forth? Or it can also could be trying to get reassurance from the partner. Some people do it more explicitly, like actually asking, like, do you love me? Do you feel excited to see me? Do you feel attracted to me? Do you think about me? Would we be together? So on and so forth.
Mm.
And now, everything I just said in itself, this is not a compulsion. This is not
Mm.
something out of the ordinary. Most people would say, like, yeah, I would like to know that my partner loves me and they're attracted to me. But it becomes reassurance seeking when those actions become reoccurring and they come as a reaction and as a response to doubts, to questions, does she love me enough? Am I in the right relationship? And this is very triggering, and then I must do something in order
Mm.
to relieve the doubt momentarily.
Yeah.
However, like every other compulsion, even if it works in the short run, it doesn't actually relieve the doubt for the long term, right? People can do this, and then after 30 minutes or 2 hours or 2 days, find themselves in the same situation. And then they keep engaging in a cycle of doing something to resolve the problem, but for the long run, they're only making the problem worse.
Mm. In your experience, seeing so many individuals and in many other cases, seeing the couple, what impact does RSCD have on the individual who's experiencing it, their intimacy, trust, the emotional closeness? And then we can even talk about the impact then on the partner and what they could possibly experience. Maybe just help us unpack a little bit about how can ROCD, have an effect on the many different domains in the individual's life?
Sure. So, of course, this differs from one person to another and from one relationship to another. But I could say that some of the common manifestations is, first of all, many people with ROCD have uh, lots of shame and guilt about their thoughts, right? I mean, being in a relationship and having those doubts, having those questions, this can feel
Mm,
something very shameful.
mm,
Some people also experience shame about misleading the partner, like me being with them while having all of those doubts,
mm,
or acting as if like I'm in the relationship, but in my
mm,
head I'm having all those doubts.
mm,
Am I not, cheating them, misleading them,
mm,
wasting their
mm.
time? This can be another great source of
Yeah.
doubt and shame. And one of the outcomes or impacts is that people often hide a lot of what they're experiencing,
Mm,
and they can sometimes be withdrawn, right? For example, withdrawn and invest less in the relationship because there is often a question of, if I'm not sure about the relationship, why invest in it?
mm.
I mean, why put all of me if I'm uncertain? And the
Sure.
agenda usually is like, I should feel certain, and then I will invest to the full extent. Right?
Mm,
Because if I
mm,
invest when I'm not certain, so I'm being, with some people, it's like untrue for myself. With others, it would be like misleading my partner and giving them the false image that I'm fully in while I'm not. Right?
mm,
So all of those issues and some additional ones can definitely impact, intimacy, connection, being fully engaged in the relationship.
mm,
And it's hard for partners to stay indifferent to it or not to notice it. Now, some individuals with ROCD are being very explicit about it. For example, some of them feel that they must confess every doubtful thought that they have, right? Which is a compulsion too, meaning like I'm feeling so bad about it, but okay, but I'm gonna
mm,
confess to my partner and
mhm,
they're gonna know
mhm.
so that it's not all about me.
Yeah.
Now, think even loving and supporting partner, it's not easy to hear on a daily basis that someone is
Mm,
having doubts about you and
mhm.
they're not necessarily attracted to you and so on and so forth.
Yeah.
In other cases, again, people really hide their thoughts, right? Saying like, this is something terrible that I cannot share with my partner. And this can also be very confusing for the partner because they don't know what's going on, but they feel their partner, withdrawn, not sharing. They see that he's going or she's going through something, but they have no idea what's going on.
Mm,
So this can be, being with someone with ROCD, and especially when you don't know enough about the condition, what's going on, this can be very confusing for the partner, and not easy. It can be worrisome as well. If you see your partner again and again struggling with something, you don't know what is it, you don't know how to help, you don't know how to support them, it can be very confusing.
mm. What would you recommend to a partner? What would you recommend that they do if they are in this situation? Um, are there resources for them? Do you recommend that they go for individual counseling so that they can, cope and deal with this? Um, and we obviously are assuming that they are aware that their partner is experiencing ROCD. What if they aren't even aware? What would you recommend that they could do?
First of all, I think that almost everything that a partner could do should be done in collaboration and discussed with the ROCD sufferer. right? This is, for example, why when you asked about having the partner joining a session, it's not
Mm.
just talking to the partner. It's something that we establish together,
Mm.
right? So it
Yeah.
cannot usually be done in just a one-sided way. If partners are lacking knowledge about the ROCD, I would say that the first step would be to gain some knowledge, to understand better
Mm.
the phenomenon. Because again, I can say that in sessions when the partner joined it and pretty much heard for the first time about what actually going on, right?
Mm.
Um, by the end of the session, they often say like, "Wow, I really understand better something that I was so confused about. Like I had
Mm.
no idea what's going on, and now I at least have a better understanding."
Mm.
It doesn't necessarily make the coping with it not challenging. It's still
Yeah.
a challenging
Yeah.
coping,
Yeah.
but at least, okay, I know what's going on
Mm.
now.
Yeah.
And after gaining this understanding, this goes back to the point we discussed earlier. And after establishing this understanding also together with the ROCD sufferer, I think that the best thing that partner can do is supporting the person, not the ROCD, by being them, being there for them with empathy and
Mm.
compassion,
Mm.
but refrain from collaborating and engaging with the compulsions. Right? You can
Mm.
think about it a little bit like someone close, a loved one, who is an addict and is on a path of rehab from alcohol or drugs or whatever, right? And then they come to you at some point and say, like, this is so difficult. I'm feeling so bad. Please just give me this one drink or this one shot or whatever. Just because I have to feel better now.
Mm. Mm.
Now, it's not an easy position to stand in when you see a loved one really struggling.
Yeah.
But you know that giving them this drink right now would
Mm.
not actually support them in the long run.
Mm.
And the best thing you can do for them is saying that, like, I see how hard is it for you.
Mm.
And I'm with you here, and I'm gonna be with you. But I really don't think that giving you, a bottle of beer or a glass of whiskey is going to support you in the long run. And I believe in your strength and ability to stay in this difficult moment without running for a drink or for compulsions.
I really like that association. It just helps people just to, I think for many people, it's just a very familiar scenario. So thank you for that. I'm very conscious of time, and I have so much more to ask you, and we might have to schedule another session later on in the year. Um, Treatment. Okay, we've spoken a little bit about it. What does success or progress look like? So what are the things that you're looking, in an individual that, oh, okay, we're on the right trajectory. They've got this, they're on the right path, we make a lot of improvement. What does improvement actually look like? And what is the ultimate goal? So what are we actually working towards? Full like cure, like there's no obsessions, there's no intrusive thoughts. Maybe just give a little bit more about what the treatment path looks like, and what are we aiming for?
Sure. So I would say that the first and maybe general framework of treatment would be taking a period of time, which is not just 1 or 2 weeks. We're usually talking about something between 6 to 8 months in general, in which the focus is putting aside engagement with the questions bothering the person, whether or not I'm in the right relationship, are we suitable, compatible enough, and so forth, and focusing on reducing compulsions the path there goes through practicing all kinds of tools and strengthening abilities to do that, because it's not a complicated task, but it's not an easy task to do.
Mhm.
And working on being more and more and more present in the relationship itself, as
Mhm.
opposed to in your mind
Mhm.
dealing with doubts and deliberations. The goal, the outcome of a successful therapy, and I would say, first of all, it's not about making the person stay in the relationship. It's also not about making the person leave the relationship, right? It's about enabling the person to choose, to actually choose whether or not to stay in the relationship, not from a place of running away and fighting off doubts, intrusive thoughts, fears, hesitations, right? And to that end, the goal is not to eliminate doubtful thoughts and unpleasant feelings. If you actually think about it, this is actually the goal of compulsion. This is what compulsion is trying to achieve. What
Yeah.
we aim for is being more and more enabled to stay with uncomfortable thoughts and feelings without reacting to them.
Yeah.
And only from this position, person can actually start experiencing more and more the relationship. And only after you experience your relationship naturally for a
Mm.
while,
Mhm.
you can actually look and choose like, okay, is this something I wanna stay in? And I can add that when I think of this process, I can think of maybe two significant shifts that people undergo throughout the process of successful ROCD therapy. We kind of mentioned them a little bit before. And the first one is, again, moving more and more from the question that people are bothered by, whether or not this is the right relationship, the right partner, the question that to the question of, how does the way I react again and again to those thoughts impacts me? What does it do to me? What does it do to my mood, to my energy, to my attention, my mental
Mhm.
capacity, my ability to be present in the relationship, and sometimes in my life, by the way,
Mhm.
right?
Yeah.
Extreme cases, more extreme cases, people with RCD can be engaged in this like all day long in those questions, including in their
Mm.
work. The second significant shift is that people can gradually start to relate to those experiences, such as doubtful and intrusive thoughts and feelings of fear or boredom or unpleasant experiences, as something human and natural that we all experience in our lives and in our relationships, as opposed to treating them every time they pop up as an indication that something is wrong. There
Mm.
is, some danger, some risk that I must react to and prevent. Those shifts, both of them, this is usually, it's not something that is this one, eureka moment that from then on
Mhm.
everything changes. It is a
Mhm.
gradual process. There
Mhm.
is often kind of back and forth, right? But when I think of the conclusion of a successful therapy, people usually can say and see that they've made a significant transition around those two areas. And one of the ways it can actually manifest, that people can say, yes, I am having some doubtful thoughts throughout the day, but when they come up, and when they come up, it's not often a pleasant experience. I mean, they can be accompanied by distress, but when they come up, I know how to acknowledge them and not having to interact with them immediately. If I believe they might be important to deal with, I will say like, I will set a time. So like, okay, so you know what, this might be something I would like to consider on, Saturday afternoon. Am I having some time off? This is the time I'm gonna think it over if it's still an issue,
Mm.
but not immediately engage with it every time this thought pops up, considering it might pop up dozens or even hundreds of times a day, so that it robs me of my time, my energy, my attention. Right? Mm. I'm going to be the one leading and in charge of my life, as
Yeah.
opposed to constantly reacting to thoughts and emotions that I have very little control over.
Thank you so much. And I have one last question for you. And before we get to some of the questions that are in the chat box, and they are, I'm really excited about that. If there is someone who's listening to this conversation and they are really identifying with what you're saying, but they're a little bit hesitant, scared, or just not really sure what to do, what would you advise them?
So, I know that a lot of what we're talking today can really sound confusing and scary to people, but the message I would like to send and convey is a message of hope.
Mhm.
Because we do know much more about ROCD today than we did 20 and 15 and 12 years ago. We know much better how to work with it. And I would suggest for those people, first of all, we could add some links to additional sources, reliable
Definitely,
sources about our
definitely.
city, to this webinar, so people can read more, can become more knowledgeable about that. And my best recommendation for someone who suspects that they might be struggling with ROCD is to schedule a meeting with an OCD specialist to undergo full assessment and to get their input on that.
Definitely. So when we will upload this session to our website and YouTube channel, we will include some additional resources that Ran will share with us. So thank you. There are some questions that I'd like to get through quickly. Ran, do you think that some of this anxiety comes from the view we can have that our partner must be all things to us all the time, like we see in films or read about in books or perceive other relationships as being? It's a really good question.
Definitely, and it is a really good question. We didn't get to discuss today on the area of what we refer to as extreme love beliefs. Okay, but I will just share about this shortly. That some people with ROCD have beliefs about the way relationship should be like, should feel like, about what we should think, feel, how we should act in a relationship. That, for example, just to be example, never having doubts, never having boredom, never having uncomfortable feelings, never looking out on other people, never feeling attracted to other people, or as in the question, like having the perfect partner that answers all of our desires, emotionally, intellectually, sexually. Now, again, those can sound like very beautiful beliefs. Yeah, I want to have the perfect partner. But the problem when hanging very tightly to those beliefs is that they leave very, very little room to experience other very natural and human experiences. Because if I hold so tightly to these beliefs, having doubt, having fear, feeling boredom, seeing something in my partner that I don't necessarily like or appreciate is tagged and sees as a problem that needs to be solved. And from there, the way into engagement in compulsions is getting shorter and shorter.
Thank you.
Yeah. And
This
this
is
is the way, this is
it,
also something usually in somewhat later stages of treatment. We definitely want to work with beliefs that people sometimes have, or maladaptive beliefs, extreme
mm,
ones that people
mm,
have about love and about relationship.
mm, 100%. This is a really good question. I'm so glad that you asked this. So what about the OCD relationship between a parent and a child? So is it possible to experience ROCD not just with an intimate partner? Can it be with another individual that you have a very close relationship with?
This is a great question.
Mm.
At the moment, there isn't sufficient research about this. There are, I believe, just a few very, very pioneering researchers that actually focused on ROCD in the parent and child relationship. But as clinicians working with OCD, definitely. I mean, we definitely see this in the clinic, and whether you want to title it as ROCD or some kind of other, it doesn't matter. The process is very, very similar. I can think of some actual and past clients that I'm working with. And again, this is it often manifests as parent like focusing on some features of the child, okay, which is very natural. Every parent wants their child to be happy, to be successful, but the preoccupation is extremely exaggerated to an extent that it brings great suffering to the parent, and often can also have a negative impact on the child. Yeah.
Thank you for that. Excellent question. And our final question for today is the approach to contamination OCD the same, that you should not engage and give reassurance to the sufferer? And how would counseling or recovery for this type of OCD look? So I know this is not maybe the topic of our webinar today, but if you could just give a quick little brief um, answer for this.
Of course. So fundamentally, the core process of OCD is what we described earlier, right? This ongoing cycle of intrusions, distress,
Mm,
obsessions, and compulsions. This cycle can catch on different topics, right? And this is why we can say like someone who deals with contamination, health issues, relationships, religion issues, harm issues. When you look from the outside, say like, what is the commonality? It looks like
mm,
completely different issues, but the process is very, very similar,
mm,
right? So in all types of OCD, what we try to teach people and help them to become better is staying with the uncomfortable and sometimes extremely uncomfortable experiences they're experiencing, but learning and strengthening that ability, say that, the fact that I'm experiencing this does not mean that I have to do anything about it, anything to resolve it. And in that sense, which is another way of saying like reducing compulsions, right?
mm,
And this is something that, of course, we will do with contamination related to OCD as well. I think in ROCD, there are some special or specific features, such as the one we spoke about today, because it's not just me, there is another person, there is a relationship involved here. And that's part of the reason that why in the treatment of ROCD there are like additional factors that we wanna work with in therapy that are not necessarily present or less present in other types of working with other types of OCD.
You have ended on the hour. We've just made it. So we are at the end of the session. It has truly been such a pleasure talking to you. Um, I really do hope that we are able to schedule another session in the near future. So thank you so much. For those who are watching, whether it's live or the recorded session, if you are interested in the Stop OCD program, you've made it to the end. We do have a promo code for you to get $100 off your first month, and that is webinar 100. If you have any questions, you can certainly send them to us at support@stopocd.com, whether it is what is the promo code, what is ROCD, what does treatment look like, what does the program entail. Any questions you have, we'll happily answer them. Again, thank you very much, Ran. Thank you to the participants who stayed with us and asked all the questions. We really appreciate you taking the time as well, and thank you.
Thank you, Miriam. I'm very happy for our talk, and once again, I'm very hopeful that it would be beneficial to listeners.
Absolutely. Absolutely. Thank you.